Hi, I'm Laura Fry-Law, and I'm an associate professor in the Department of Physical Therapy and Rehabilitation Science, and today I'm going to be speaking on strength and fatigue with aging. I have no disclosures. So what we're going to be focusing on today is talking about sarcopenia, characterizing strength and fatigue changes with aging, and then contrast what people have shown in research for changes in muscle fatigue properties with what we see anecdotally when we talk to older adults, and then present to you a theoretical model that helps explain some of the interplay between changes in strength and changes in fatigue that sometimes are not always immediately obvious. So just a quick review. Muscle physiology is highly complex, but it can be simplified down in many ways. So we start with the alpha motor neuron that comes from the spinal cord and descends out into the muscle. That alpha motor neuron hits the neuromuscular junction where it activates the muscle with calcium release that then leads to the muscle contraction. And then, of course, we get force from the shortening muscle through the connections of the tendons at the bone. So muscle only acts by shortening and pulling, which creates the force between two adjacent bones. This whole process is a conversion of electrical stimulus from the brain to a mechanical response, which we often call the EC coupling. And where it's going to come up a little bit later on is that we have different types of muscle in our bodies. We have slow muscle, intermediate muscle, and fast muscle. And each muscle is comprised of multiple fibers of each of these slow, intermediate, and fast fibers, which are also sometimes called type 1 or slow oxidative, type 2A or fast oxidative glycolytic, or type 2X, fast glycolytic. The main point I want you to think about in where we're talking with changes with aging is considering these general types in a broad sense of these slower muscle fibers to the fast muscle fibers. But we're not going to get into the nitty-gritty details of each specific fiber type specifically. Now, these motor unit and fiber types typically are characterized into these three groups, but actually it's a continuum. So we like to characterize because we like to make the world simple and easier for ourselves to understand, but in actuality there is some continuum. So while we talk about slow fibers as being more aerobic and oxidative, they tend to have smaller axons and they tend to have a little bit less force, lower peak force, and lower intensity activities. There is still a little bit of a range as you get to your fast fatigue resistant or intermediate fibers and into your fast fatigable, high force, high fatigable fibers. Most of our muscles are comprised of this mix, but as we age, I will talk a little later about some of the changes we see in these fiber types within our muscles. So to start with, let's just define sarcopenia. Now, most of you have probably all heard of the term sarcopenia. According to dictionary.com, it's defined as a loss of muscle tissue as a natural part of the aging process. And Merriam-Webster's dictionary defines it as a reduction in skeletal muscle mass due to aging. So by definition, sarcopenia is an age-related loss in muscle mass. Now there's another term that's not used as frequently, but I want to present it, and I will be using the terms interchangeably, is dynapenia. Now the Greek translation of dynapenia is poverty of strength, power, or force, where dyne is the Greek for force. So we talk about dynamometers, and that is more technically correct in the sense of what we usually evaluate. We evaluate usually loss of strength with people with aging. Whereas sarcopenia, the Greek component of sarco is flesh. So it's actually the muscle mass loss, but we're not usually measuring muscle mass. Now we may visually see loss of muscle mass with sarcopenia, but more often we're actually assessing dynapenia. However, we're going to use the terms interchangeably. So strength loss. let's talk about strength loss with aging. Here is a graph from a study from some authors back in 2000. Stoll did an evaluation of a large number of healthy adults across a wide range of ages. So this is a cross-sectional study, not a longitudinal, and they assessed multiple different muscle joint regions throughout the body, from hand and grip to the legs and the arms, with isometric exercises. And they evaluated peak torque and then came up with a index, if you will, which here they call the muscle strength index. And if you look at this, if you look towards the left, you see the 20s, 30s, 40s, it's pretty flat. So there might be a little bit of a decay between age 20 and 40 in peak strength, but it's not very dramatic. Where we start to see the fairly noticeable shift is after the age of 50, that about 1 to 2% of your peak strength can decline every year after the age of 50. And this is observed generally throughout the body. So it is not necessarily just certain muscles that are more affected. And we do see this even in masters athletes, suggesting that this is an age-related change, potentially at the cell level. However, there is likely components of disuse and reduced activity, that after the age of 50, we may be less active. Then that disuse leads to more strength loss, which tends to lead to more inactivity, and it becomes a vicious cycle of decreased strength, decreased activity, leading to more decreased strength, etc. So this sarcopenia, or dynapenia, that is seen after the age of 50 is likely due to two components, one of them which is more reversible and one which we have less that we can do something about. Now, there are physical activity guidelines for Americans that are available on the health.gov website. If you haven't seen these, I'm sure you've heard of the American College of Sports Medicine physical activity guidelines, but essentially, guidelines suggest that you need to avoid inactivity, that all adults, whether you have a disease, whether you are healthy, whether you're young, or whether you're old, that avoiding inactivity is the number one priority. Now, I know you have another lecture about exercise in older adults, so we're not going to focus on that component, but I wanted to address this because the part that most people remember is the first part here, where 150 minutes per week of moderate physical activity, which is basically 30 minutes a day, 5 times a week. Now, that is a very important component, but what people often forget is the guidelines also indicate we really need 2 days a week of some form of muscle strengthening. So often when people are assessing whether someone is meeting physical activity guidelines, they're only looking at that 150 minutes of moderate physical activity and forgetting about the muscle strengthening. But even older adults benefit from muscle strengthening. And hopefully by the end of this presentation, you'll have a better understanding of why that may be so important, or at least a few reasons why. So strength and fatigue in general are two different components related to muscle function and physical activity that are related and yet are distinct. Both of them are influenced by many factors. So your training level, how intense you are working will influence your fatigue. The muscle or joint that we're talking about can vary. You could be strong at one muscle but not as strong at another. Whether you're male or female has influences on your strength and fatigue. The type of task that you're doing can influence, for example, fatigue, but the one we are really focusing on today is age, and what is the influence of age on strength and fatigue. So when we talk about reversing sarcopenia or potentially preventing sarcopenia, there are several issues that we should consider. Number one is a concept called specificity of training. Now, this concept is a basic principle of athletic training or health promotion, and essentially what it means is that what you train is what is changed. Essentially, if you train certain muscles those muscles are going to be the muscles that see the improvement, that it may not always transfer to other body regions. So another example is aerobic training. Let's say going for a walk may not effectively reverse sarcopenia because it's focusing on aerobic and working the heart, and it may not be enough resistance to induce strength changes in various muscles. Now, it might be sufficient for the legs if the legs are not getting a lot of resistance exercise, that walking may be sufficient, but it may not do much for the upper body. Or conversely, if we added resistance training to the upper body, that may not be helpful for the lower body. So when working on addressing sarcopenia with aging, ideally you do want to hit multiple muscles of the body or involve activities that target and use multiple muscles of the body. Now, resistance training can sound really intimidating, particularly when we're dealing with older adults or frail adults or people who have various medical or functional limitations. There are many forms available of resistance training that can be helpful for reversing or preventing sarcopenia. Body weight resistance, simply lifting your limbs against the gravity, can work as resistance exercise, things like yoga or Tai Chi, and it is dependent on each individual. The focus is that you have to do exercise that's simply a little bit beyond baseline. So if you are an incredibly strong person, doing those simple exercises are not going to be enough to induce any type of change. You won't get an adaptation because you're already stronger than those exercises are requiring. However, if you take someone who is very deconditioned, even some simple, what may seem like easy exercises can have a significant effect and improve strength. So the second issue that I want to deal with is a timeline for strength improvements. What can you expect to be able to change, and is it even worth trying to change? I hear people say, oh, it would take too long and I don't have time for it, or it's not going to have a significant effect on me. So as a project with a group of students in my lab, we wanted to address the question, well, how quickly can we see strength changes? We found 244 studies that dealt with some form of resistance training and pulled data where they had done a baseline strength assessment and then a strength assessment at 2, 3 to 4, or 5 to 6 weeks. And we pulled every study that we could find using all ages and populations, whether they were patient populations or athletes, and first did an overall evaluation and found that in only 2 weeks, we saw an average of about a 15% improvement. And by 5 to 6 weeks, that was a little over 20%, about 22%. Then we broke it down into males and females and whether they had been previously at a trained level or a fairly untrained level. So trained typically meant healthy adults who were already doing a fair amount of physical activity. Could have been all the way to athletes, or it could have just been individuals who were recreational athletes. And it's a little difficult to see these values, but in general, the hashed little bit darker columns, they are the trained individuals. And the blue unhashed or slightly lighter columns are the untrained. And in general, the untrained individuals show more improvement than trained individuals in the first 5 to 6 weeks. Now, there weren't always every data on each population available, so we were not able to find any female trained at 2 weeks, which is interesting in that that was not a part of those 244 studies. But in general, we see the best improvement in people who are untrained. Essentially, the lower your baseline, the more potential you have for improvement. Then we also looked at separating those out into people who were 55 years and older or under 55. And again, same influence, that we actually saw the best improvement in those over 55. And at 5 to 6 weeks, it was nearly double. So the average at 5 to 6 weeks was close to 40% improvement in strength. Now, again, likely those populations studied were starting from a lower baseline. So 40% of a lower baseline is not as large of a magnitude of change. So if you, on average, could lift, just to keep the numbers easy, let's say 100 pounds, then 40% improvement would be 140 pounds, like a leg press, let's say. Not that these all use leg press. However, if you were able to lift initially 200 pounds at baseline, then even being at half that improvement could still get you a 40-pound improvement, even if you only had a 20%. So it's different in absolute versus relative. However, but it does suggest that there is room for improvement, that strength loss is reversible with older adults, and many of these were patient populations as well. Now, another issue that we often deal with across the lifespan, but particularly with older adults, is the issue of pain. There's a number of conditions that can result in muscle and joint pain that can have an effect on strength. For example, knee osteoarthritis. In this study, a study done in Denmark by Henriksen et al., they used a model of knee OA, an experimental knee pain where they actually inject a saline solution into the fat pad of the knee. And it's a small amount injected, and it induces a temporary knee pain. So what they can do with that is they can evaluate baseline strength, they can do the injection so that now they've added pain to the equation, retest strength, then over a few minutes that pain it goes away, it resolves, then they can test the strength again to look at recovery. They did it in two different conditions. They used a hypertonic saline, which is a salt water that is a little extra sodium, and it's a fairly painful, or it can be painful. And then they did an isotonic saline, meaning a normal saltwater solution that matches the body's salt content, which is not particularly painful. In this graph, they show 4 conditions of strength assessments. They did isometric, they did isokinetic, meaning a constant speed of knee extension and flexion. So they sit these people in a machine that can assess peak strength, and they kick out and they pull back as hard as they can at 60 degrees per second, 120 degrees per second, or 180 degrees per second. And at each of these columns, there's a little word that says pre. That's the baseline before the injection. And they rated their pain after they did their strength assessment, and you can see there's no pain. And then it says during. And in the during, they had them do their strength assessment and rate the pain that they felt while doing the strength assessment. And then the recovery is when they did the strength assessment after the knee pain had largely resolved, and asked them to rate the pain again. So what you see here is on a VAS, or visual analog scale, from 0 to 100 millimeters. On average, it was around a 30, technically it was 32, but on a 0 to 10 scale, that would translate to about a 3. So that was some moderate knee pain, and they assessed strength before, during, and after. And what they found is in each of these graphs, we see the white is the knee pain condition with the hypertonic saline, and the gray bars is the control condition with the normal saline, meaning it was not painful. And you can see the pre, which was just their peak strength on average for kicking out, then the during, and you can see the drop in the white columns in each of those conditions of isometric, 60 degrees per second, 120 degrees per second, and 180 degrees per second. And then it does recover when the pain recovers, but not necessarily 100%. In the first two conditions of isometric and 60 degrees per second, there was still a lasting loss of strength because of that experimental knee pain. And in general, with the knee pain, their ability to produce peak torque declined by 12 to 15%. So that would suggest that sometimes what we may perceive as sarcopenia may actually be dynapenia due to pain as opposed to actual loss of muscle mass. The best thing we can do there is to work on reducing pain when possible. So some key points that I want you to remember from what we've talked so far about muscle strength is that muscle strength is influenced by a number of factors, some of which we didn't get into a lot, but individual differences between each individual, that some people are naturally just more bulky, they tended to always be stronger, whether they're male or female can also influence it, their previous activity or training level, whether or not they have pain, and then of course their age. That we often see this decline with age, but that does not make it an excuse because we do know it's reversible to some degree. And hopefully you've gained a better understanding of some of the strength changes with aging, that there is strength loss that we need to be watching for, that we can encourage our patients and our clients to include some form of resistance exercise in their daily routines. And it doesn't have to be this formal weightlifting. It can be very functional activities, and that to understand there is likely an age-related component that we are not going to have a direct effect on likely, but that the disuse component is reversible. So let's move into fatigue. So fatigue is a tough word because we use it in so many different ways. It can be a noun or a verb. That some definitions from dictionary.com are fatigue is extreme tiredness typically resulting from mental or physical exertion, or as a verb that fatigue that it can cause someone to feel tired or exhausted. Now Merriam-Webster's dictionary just uses a noun, although we do know people use it as a verb as well, where they define it as weariness or exhaustion from labor, exertion, or stress, or the temporary loss of power to respond that is induced in a sensory receptor or motor end organ by continued stimulation. So that's a much more physiologic definition of fatigue. And of course, both of these address the fact that there is a mental component and a physical component. We're going to talk largely about physical fatigue, but mental fatigue is also an important issue that could be a whole topic by itself. So when we deal with physical fatigue, even within that limitation, where we're not dealing with that mental fatigue of, oh, I just feel so tired, I can't even think straight, but the physical fatigue where you feel tired, you feel like you can't do anything, which is a perception of fatigue, but there's also a measurable component of fatigue, a measurable loss of muscle force. And those two are often related, but they can also be distinct, where you may feel fatigue, but not actually have a measurable loss of force. I use the example sometimes of if you have been laying on the couch all day and yet you feel really tired. You're not actually have a loss in muscle force because you haven't done anything, but you may still feel like you would not be able to get up and do a lot of activity. On the other hand, you sometimes have that measurable loss of force, like you just did a lot of activity, and maybe your muscles feel a little quivery or like jelly, but you actually feel fairly alert. So you can have these vary together, or they can vary separately. We're going to focus on really the force loss component of muscle fatigue because of activity. So to assess muscle fatigue, we could use a survey where we just ask someone, how fatigued do you feel? But typically for assessing muscle fatigue properties, we want to actually assess the muscle force. So a standard way we do that in the laboratory setting so that we can study muscle fatigue properties is we use relative intensity tasks, where we normalize the task to each individual. That way we're not comparing apples to oranges in a sense, because each person has a different strength. We just talked about variability and strength between people. So to test fatigue and to characterize fatigue between individuals in a laboratory setting, we typically will assess the peak torque of a muscle or muscle group using an isometric contraction. So we put them in a machine like an isokinetic dynamometer, which is the type of machine the study I just talked a few minutes ago used. And let's say we use the elbow. We would put the elbow and have it all set up and ask them to push as hard as they can against the dynamometer. And isometric means that they're not going to move. It's just going to hold them at a set angle. And they'll contract as hard as they can. We usually give them visual feedback and some verbal encouragement and get their peak force, the most force they can achieve, what we call an MVC. And then we would take that information and then we'd ask them to do a sub-maximal task, like, for example, 50% of their MVC, or it could be 30% or 60%. There's all different conditions that people have studied, and we'd ask them to contract at, for example, 50% MVC until they can't hold it anymore. Or maybe we would just do it for a set period of time and then reassess their strength at the end. But that is one way that we can study muscle fatigue properties across individuals and normalize for their strength by doing it at a percentage of their maximum. So what we've done is pulled data from every study that we could find that used this technique, where they used a percentage of the maximum and they assessed how long this group of people could sustain that contraction at that percentage of maximum, and we looked at multiple different joints. So we had done a meta-analysis. We found back in 2010, we published this, where we had found 194 studies with over 300 data points. Some studies had more than one data point, where they maybe had more than one intensity or did more than one joint. And we plot this where on the x-axis, what you see is the intensity, where 0, there are no tests at 0, but 0 means basically no intensity, and all the way to 1 is the same as 100% intensity, would be the maximum effort. And then the y-axis is the endurance time, or how long they could sustain that contraction. Now what you can see is we see this curvilinear relationship. What that means is, as the task gets easier and easier as a percentage of maximum, the longer and longer you can sustain that. And we all know that anecdotally, if you are holding something heavy, you can't hold it as long as if you're holding something light. So that's not anything surprising, but we do are able to characterize this nonlinear relationship between endurance and fatigability and intensity, where as it gets more and more intense, our endurance becomes much, much, much shorter. So we can use this to characterize different populations. So this is data on average across predominantly young adults. And what we found in this young adult group is that each joint area or muscles surrounding that joint actually varied from each other. So the ankle is in this first graph on the left, where the darker circles are the ankle and the lighter circles are the shoulder, where at the same intensity of percentage of maximum for that joint region, for example, if we look at 0.3 or 30% of maximum, you can see for the ankle, they could sustain that for about 400 seconds, but at the shoulder, it was under 200 seconds. So the ankle is twice as fatigue resistant as the shoulder, which makes sense. We use our ankle every single day. Every time we're standing and walking, those ankle muscles are helping keeping us upright. Whereas our shoulders, we tend to do more for short duration activities. So we know there's differences between each joint in endurance. And what we found is, in general, the ankle is the most enduring, and all the way to the shoulder was the least enduring. And in the middle is the elbow and the hand and grip and knee. But ankle and back, our most postural muscles, are the most endurant. We also found that females typically have better endurance at these relative task intensities than males. Now, one of the issues that we found was that some studies were done by labs that typically use the elbow, the example I talked about first. These Hunter studies have said, oh, women have better endurance properties than males, and they did all elbow studies. But another lab, Kent Braun, that has studied males and females and aging, has found that they didn't always see it. So one of the things we did with a student group is we did a small study where we asked 16 men and 16 females to do both the ankle test and the elbow test, and in the same individuals, we found that the women had better endurance at the elbow, but not at the ankle. So some of these differences are not widespread, saying that women are always have better endurance, but they can be muscle specific. Now, similarly, we analyzed older versus younger adults. So again, using these relative isometric tasks, we only found 46 publications, but still we found 46 studies that had evaluated fatigue in young versus old in the same study, doing some form of relative task, predominantly isometric, although we did find one or two dynamic using isokinetic testing. And overall, what has been seen across all these studies that used different joint regions was that older adults show better fatigue resistance than young adults. Now, you may have heard that before, or that may be some concept that's completely new to you, because that seems to go completely opposite to when we talk to older adults and they tell us that they fatigue easier, that they're tired, or they can't do as much compared to a young adult. But over and over, studies have shown using these relative isometric tasks that older adults are more fatigue resistant than young adults. And it does seem to be more universal, not necessarily as joint dependent as we saw with males and females. And it didn't matter whether it was a sustained task with no rest periods or whether we did tasks or the studies did tasks where they had a isometric and then a rest period, then an isometric and a rest period. So both of those actually showed improved fatigue resistance in old adults. Now the circled data point on the right shows that in the fewer studies that used isokinetics, that there was no difference in young versus old adults. Now, it wasn't that the young were better, but that the advantage for older adults was lost once there was motion involved in the test. But the isometric conditions, which is our most common way of studying this muscle property, was definitely advantage to the older adults. So some of these physiologic changes in muscle properties with aging is that older adults do have more fatigue-resistant muscle. So let's go back to those type 1 and 2 muscle fibers we talked about at the very beginning. People have found that older adults have a preferential loss of type 2 fibers. Those are the high force, high intensity fibers. They potentially are not using them as much, so it could be in part a disuse adaptation, but it may also be a preferential aging cellular level adaptation. We don't know for sure, but what it does is it leaves more type 1 fibers. So if you only lose a few type 2, then even if you're not gaining type 1, it just leaves the proportion in that muscle belly to be more type 1 fibers. Those type 1 fibers are our slow fatigue resistant fibers. They don't generally have as much peak torque, which goes along with our loss of strength with aging, but they are more fatigue resistant. So that may help explain some of these changes in fatigue properties that we see with our isolated studies. However, that still leaves the question. Older adults often tell us that they feel more fatigue, so we should think based on these physiology studies that they should feel less fatigue, right? But no, they usually don't. So why? So to address this question, we again tried to model these endurance time intensity relationships in older adults. So I showed you those data earlier where we modeled with young adults this nonlinear relationship between how long someone can sustain a task and the intensity of the task. There's not as many data points for old adults as we had for young adults, but we were able to take the data of how different old adults are from young adults and then use that to model a shift in that curve where we have pretty strong confidence that the young adult curve is representative of ability, fatigability of the average, if you will, healthy young adult, and shift it for the old adult, where we found it shifts approximately 20 to 25%. It is dependent a little bit on the intensity, but that endurance curve shifts up for older adults, that the fatigue property of muscle is more fatigue resistant with aging, where if you look at the dotted line on the left, what a task for a young adult at 25% of their maximum, maybe they can sustain for just under 400 seconds, but an older adult asked to sustain a 25% of their maximum might be closer to 450 seconds. So that is the model of the shift in fatigue properties at the muscle level or joint level that's due to aging. However, most tasks that we do in everyday life, we don't do based on our maximum. They're not a percentage of maximum. So our functional tasks still require whatever level of force it is to do them. So getting up out of a chair, getting up from sitting, you have to lift your body weight. If we assume our body weight hasn't changed from young to old, now obviously that is a big assumption, but body weight can go up, it can go down, but if we assume it hasn't changed, then if we get weaker and weaker, then the percent effort to get out of a chair goes up as we get weaker. So no longer can we compare 25% of max to 25% of max. Now the task is a higher percentage of maximum, which will shift you on that curve of endurance time versus intensity. Another example might be carrying something like groceries or laundry. Now granted, you may choose to use smaller bags and smaller loads of laundry in order to accommodate your increased strength loss as you age. But in general, that functional task, if you want to carry 20 pounds or you have to carry 20 pounds, that may have only been 10% of your maximum when you were 25. It might be 30% of your maximum when you're 60. So the percent of max is no longer constant. So while we use that to study fatigue properties, it loses its relevance when we transition into functional tasks and everyday living. So if we use this model to better understand this interplay between strength and fatigue and the changes in strength and fatigue with aging, then we can begin to assess what is the effect of weakness on endurance and fatigability. So if we have no strength loss with aging, if someone were able to maintain their strength, but they still were able to have this improvement in fatigue properties, then we would see, for example, if doing a 30% maximum task, that older adults should be able to sustain that task 23% longer, for example, using this model. Now, what if there is a 10% strength loss? So a 30% of maximum task, let's just make the math really easy and say it requires 30 pounds and that the peak ability is 100 pounds. Maybe that is of leg strength for getting out of a chair. So let's say it takes 30% of max to do that. If we have a 10% loss in strength, that changes the denominator from 100 down to 90. So 30 is the requirement of the task. That hasn't changed, but now someone is only able to do 90. That means that task is now requiring 33% maximum effort. Now that may not sound like a big change with a 10% loss, that task went from 30 to 33%. But because of the nonlinear relationship of this endurance time to intensity, depending on where you are in that relationship, it can have a fairly substantial effect. So particularly at low intensity tasks where that curve is very vertical, small changes can have a dramatic effect. So if we move over to 33% and we compare the 30% blue line where it attaches against the solid blue line to the 33% on the older adult line, we actually get to almost exactly the same endurance time. So only a 10% loss in strength makes up for that 20% improvement in fatigue resistance, particularly at these low intensities where we are often doing our functional tasks. What if we have an even bigger strength loss? What if we have a 30% strength loss? Well, that task of 30 pounds now is divided by a maximum of only 70, or take 100 minus 30. That 30 divided by 70 is now a 43% effort. So let's shift over to this 43% effort, where a 30% loss in strength makes older adults have a 44% shorter endurance. So that helps explain how we can see these muscle fatigue properties actually improve with age, and yet people who are older who may have strength loss can have less endurance and more fatigue because they're actively working at a higher percent in everything they do. Walking around, getting out of a chair, going up and down stairs, doing their laundry is all, instead of being maybe in the 20 to 30% range of effort, is now going into the 40% and 50% effort, and sometimes even higher. So these differences, while there may still be muscle property improvements, can be more than overcome by strength loss. So for example, if we go back to this data from Stoll that showed this loss of strength over time with aging, and this dotted line I've added is at about a 30% loss. So I took that 70 range that was the average percent index that they had, a strength index they came up with for the 20 to 40-year-olds, and then took 30% of that, it drops to about 45. Now note, it's not showing you the full scale, so you don't see all the way down to 0. So that may look like more than a 30% loss, but that is actually where a 30% loss might be. And note that that is not uncommon by the age of 75 to be maybe potentially at a 30% loss compared to where they may have been when they were 20, 30, or 40. So the take-home messages are that strength and endurance are inherently related. While we train often specific to strength with resistance and endurance with our aerobic activities like walking, strength declines with age after the 5th decade, while muscle fatigue properties improve with age. So they have these opposite influences as natural response to aging. We can train them separately, however, they still affect each other. So the strength loss can often result in greater fatigue with functional tasks because of the shift in the intensity or the effort required to perform that task. So maintenance or gains in strength may outweigh similar benefits in age-related changes in this fatigue resistance. So we know that human performance is optimal when muscle strength and fatigue are optimal. So ideally, this hopefully will help encourage you to work with people that you are working with to encourage 2 days a week of strengthening, even if it's a very low resistance, and not just endurance or aerobic activities, because it may have a larger benefit. It has the potential to have a larger benefit on their overall endurance and ability to complete functional tasks. So what are some examples? It can be things as simple as standing wall push-ups against a wall, or doing small mini squats while holding onto a chair or a countertop, or even while seated doing some arm exercises with very light weights or extending the legs out. And even incorporating it into other functional and aerobic activities, like some people may have an opportunity to do water aerobics or water walking where they get more resistance to their movement, or Tai Chi or other meditative movements like yoga that have shown to have strengthening components as well as balance and some aerobic as well. So there are a number of examples of ways to incorporate resistance training into older adults' daily lives without it being going to the gym and using weights. There are just a few potential concerns and considerations I want you to be aware of, though. Number one effect of resistance training can be delayed onset muscle soreness. Now, most of us have all felt that DOMS, delayed onset muscle soreness, that can happen 1 to 2 days after doing resistance training or any kind of unaccustomed exercise. Now, this occurs predominantly from eccentric or lengthening muscle contractions. It is not due to lactic acid buildup. So you may still hear people say, oh, it's lactic acid buildup, but it is not lactic acid buildup. If you were to do a wall sit and that immediate burn you get in your muscle from the wall sit, that might be lactic acid buildup. But as soon as you stop, your body flushes that out of your muscle and you no longer have an acidic condition in your muscle. So it is likely a combination of micromuscle damage and inflammation that's part of the rebuilding and adaptation process. Now, this eccentric component means lengthening. So if I'm holding a weight in my hand and I'm doing elbow curls, as I lift, my muscle's shortening. But as I lower it, I'm resisting gravity and my muscle is having to lengthen, but I'm still contracting it. I'm not pushing with my triceps. I'm still using my biceps, but I'm lowering it. It's the lowering phase that causes delayed onset muscle soreness. So typically isometric exercises will typically not produce delayed onset muscle soreness. And so you don't want to overdo eccentrics or negatives if you're new to resistance training, but it's still a valuable component in terms of creating this adaptation. The only serious medical condition that you should all be aware of with high resistance training is rhabdomyolysis. And this serious medical condition is a result of muscle injury. It can happen from like a crush injury from like an accident, but it can also happen because of resistance exercise. Now, typically in older adults, this would not be typical. You wouldn't usually work hard enough to induce rhabdomyolysis, but if someone were to do a lot of resistance exercise and potentially combined with some other factors like alcohol or high heat, you can induce this flood of muscle breakdown proteins to the kidneys, and it can result in kidney failure. If someone has kidney problems, that might be another reason to be cautious in not overdoing your resistance exercise with high resistance. But if you were to have someone who's done a lot of resistance exercise, they report having severe muscle soreness and dark red or dark brown urine, then you should have them seek medical attention for the potential of having rhabdomyolysis and have it treated. But otherwise, resistance exercise is typically fairly safe. Watch for pain with the exercise, try to minimize pain, and work on incorporating it into functional activities if it's going to be something that is more likely to be maintained. So just acknowledge the many people who've worked with me to help me do some of these studies, and thank you for your time.